My name is Shaun McCann. I'm conducting a series of expert interviews on behalf of the European Hematology Association at the annual meeting of the American Society of Hematology, which this year is in Orlando in Florida. And with me I have Jane Haskins. You're very welcome, Dee. Thank you for coming along.
Nice to meet you, Shaun.
And she is Associate Professor in the Department of Hematology at St. Jude's Children's Research Hospital, and she's an expert on sickle cell disease. So we were having a little chat before we started, but it's noticeable to me over a long period of time, shall we say, that sickle cell disease, which was ignored really until, I would say, the 90s, is now a major and prominent feature of ASH. Is that a fair comment?
That is absolutely a fair comment. I would say we are experiencing an explosion in the field right now with the new drug therapies, with a true increased interest for sickle cell disease and the patients. And our patients are speaking up, which is also something new. So it's an exciting time.
So which of those is the predominant reason why we're talking about it? Is it because of the patients or because of the investigators or the politicians?
I think it's because the interest rose to the top of the list, sickle cell disease, and now the drug companies are investing in new treatments. We have new drugs, we have curative treatments, we have gene therapy. Several biotechs are developing gene therapy trials. I think this is completely changing the dynamics of the field.
Right.
Yes.
Now, from what I have a little bit of background reading, I'm interested in the social aspects of sickle cell disease, because the biochemistry and all that, it's pretty easy to read about, but you're involved in that. So adolescents with sickle cell disease seem to have a very poor outcome in this country. Is that a fair statement?
That's a fair statement. I would say it's a combination of factors with the adolescents. They have a chronic disease, they're aging, they're learning to become adults, and they're faced with a lot of decisions at the same time that they're facing the fact that their disease is becoming more severe. So now they're leaving pediatric care, they're making decisions about, do I go to college, do I find a job, do I apply for disability because I feel too sick, and the disease is getting worse.
Okay. I spoke to Michael DeBohm a couple of years ago at this meeting, and he said to me, again, that adolescence was a difficult time, but a lot of physicians don't want to take on the care of adolescents. Is that still?
They're challenging. They're challenging.
I like that word. I never quite know what it means.
They are the ones who intrigue me the most and keep me engaged the most.
Right.
They keep me up at night too. They're very poorly adherent to their medications. They're not very compliant to their treatments for multiple reasons, and I love to spend time thinking about how to keep them engaged.
Okay, well, share your thoughts with us then. Why? I mean, adolescents are difficult. I mean, I have children.
They're difficult.
I have grandchildren.
Yes.
These are particularly difficult. Are they?
Oh, they're difficult. Yeah, they are. I mean, they. Over the years, I've learned to connect with them, and that's really key, right? I walk in a room and I look at them, and they know I'm for real, right? So if they don't think I'm for real, they won't pay attention to me. But I've taken advantage of technology, so the cell phone. So let me give you the example from, it was 2008, I want to say 2007, 2008. I walked in the room. I was early on in my adolescent experience, right? Adolescents with sickle cell disease. I walk in the room and I'm talking to this 15-year-old and I'm saying, this is why your medicine is important. This is why your disease is the way it is, because you're not taking your medicine. And he's on his cell phone, right? His mother's here on her cell phone.
Right.
They're completely ignoring me. And I'm talking and talking. I go, you know what? What is your number? And he goes, 901, blah, blah, blah. So I wrote it down. I walked out, closed the door, and I texted him. What I wanted to say.
And he
responded. Well, first he was shocked. He responded. I walked back. He was laughing and smiling. And I go, can we talk now through this? And he said, yeah, I guess. And then the light bulb went up, right? So then I went to my IT, my information technology people, and I said, I want to develop an app that sends messages to my patients that does not come from my personal phone because I don't want him to have my number, right?
Oh, sure.
And it took about a year, and they did. So the server of St. Jude started sending messages to them. But then I said, okay, I can't just write the message, right? They're going to ignore my message. The text message works for maybe 5 minutes, right? And then you lose interest. So then I started saying, okay, you're going to write a message for your best friends, your girlfriend, and you're going to tell them what you would tell them if you wanted to say something to him or her, your girlfriend, your best friend. And they went, oh, yeah, I guess I'll say, hey, bro, don't be a loser, take your medicine. So I started putting those messages on and I have the best back. I have a collection of great messages that sometimes they mean nothing to me, but they mean something to them.
A different language.
A different language. And, and it worked. And I looked at the adherence and the response to treatment improved. So then I went on to develop a real app, which I'm testing now, an app that does lots of things that you download from the App Store and then does lots of this. So that's one thing. The other thing is I realized it has to matter to them. If it doesn't matter to you, because adolescents think about today, maybe tomorrow, 2 days from now, forget, right?
Yes.
They can't see the long term. It just doesn't exist. Future doesn't exist. Today exists.
Right.
So you need to make it interesting for now. So that's how those tools that I have learned over the
So you're a
years.
psychologist as well?
No, I'm not I work with a lot of psychologists. I do work with a very smart group of psychologists who are wonderful. But no, I don't. But it actually has helped me now that my son is becoming an adolescent. He's 11. He's pre-adolescent. Actually, having dealt with adolescents for so many years, it's kind of helping me now figure it out. My son, which is hard.
Yes.
Very hard.
Been there, done that, as they say. And a simple and effective and a cheap treatment is hydroxyurea.
Yes.
But there's still a lot of resistance to that, is that correct?
So that's one of the things that the app that we're developing and testing does. So what happens that people don't believe and they don't like the side effects. So it's hard for them to see, the forest for the trees, right? They really have to, okay, yes, my hair may thin out. I may get some spots in my mouth. My skin may get darker. But I won't be in a hospital. I won't be admitted. But then again, right? So then they see, it's hard for them to see the benefits. So one of the things that the app does is try to, you can monitor your pain versus your adherence. You can graph it and visually see, okay, the days that I didn't take my medicine or the days that I had more pain, right? So really there's a relationship between taking my medicine and doing well. So those things that I think technology can help us. But it's, again, back to, I take today something that may work next week or in 2 weeks, right?
Not relevant.
Not relevant, right? Yeah. But if they hear from people, same age group, going through the same experience, that might click, right, to them.
Right. So, thank you. The management of pain, then, you have a psychological intervention as opposed to just giving opiates, or just talk to me a little bit about that.
Yeah, so it's not something that I have investigated, but my colleagues have. So there are lots of behavior intervention, cognitive behavior interventions that they can use with CBT, cognitive behavior therapies.
Yes.
So you can do that through apps, websites. So there are colleagues at my institution who use that. So you can try that to avoid opioids. But sometimes the reality is the pain is too strong, and you do have to use opioids.
Well, are they relatively successful, or?
Some of them are, but again, you have to be engaged. You have to use it, and you have to be consistent with the use of those cognitive behavior therapies. Yeah.
So they would be an adjunct to opiates.
That's how I see them. That's exactly how I see them. I don't think I think they work with medication. They may decrease the amount of medication you take. I don't think they replace.
Okay. In spite of all our interventions, or your interventions, I should say, I know nothing about this disease, the average lifespan of a person with sickle cell is about
48 years.
So it's still
very
about half what hopefully ours is. Isn't
so
it?
the recent data shows that it's about 20 years less than, so in the U.S., sickle cell disease affects primarily African Americans, right?
Of course, yes.
So then when you compare the lifespan of an African American with the lifespan of a person with sickle cell disease who's also African Americans, there's a 20-year difference. They die about 20 years earlier.
And there's a difference between an Afro-American lifespan and a Caucasian lifespan still. Is that
There
right?
there is a gap
Which
between.
is hard to understand, or is it?
Yeah, it's complicated, right? But I think it has to do with poverty, access to care. So I think it's complicated, yeah. But yes, African Americans in general live less than Caucasians in the U.S.
So why do they die?
They die of cardiovascular disease. They die of violent deaths. So shot, they get shot, they get killed, right? So
It's in a strange country.
it's a strange country.
I mean, people shoot each other apparently every day in this country.
That's right.
I'm afraid to cross the street anymore
I know,
when I
yeah.
see a police car in the
We
corner.
never know.
Okay, one of the causes, I understand anyway, of sudden death is HOCM, hypertrophic cardiomyopathy.
Correct. So heart disease,
Yeah.
yeah, that's a big one. So it's interesting because it is cause number one of death, cardiopulmonary diseases, and we think a lot has to do with the way your heart is, and we don't understand as well the pathophysiology. How do you come to develop heart disease? So I work with some cardiologists at my institution, and there are some investigators at my institution who are looking at this issue, and some people around the country are looking at that. So fascinating because it starts early. It starts when you're a child with no symptoms, right? But it's there. And then
And do we know why that occurs in childhood? I mean,
I think it's damage to the muscle of the heart from the sickle cell. The sickle cells, constant ischemia, right? Lack of oxygenation and occlusion of the vessels in the heart, and then that leads to fibrosis. And we think that's a part of the pathophysiology, but it's more complex than that. There are problems in the lungs, the build-up pressure in the lungs, called pulmonary hypertension.
Yes.
So it's a combination of things. But anyway, one thing leads to the other too. They feed on each other. But in any way, the sad part about heart disease is that there's no much of a warning sign. So it's there, right? And they're silent, and all of a sudden you die.
So sudden death.
Sudden death. All of a sudden, poof, you're gone. Yeah. And to do autopsies, the heart is big and it's stiff, diastolic dysfunction.
Okay. So do you screen people for these problems, or you?
Very interesting.
I mean, there's no one waiting until they're dead, obviously.
National guidelines do not recommend it. My personal bias is that we should.
Okay.
I personally do in my patients. I do an echocardiogram when they're adolescents. I do another one when they're young adults. I do because I want to catch it early, and I send them to the cardiologists.
What do they do?
They treat the hypertension. So some of them are hypertensive. It's associated, right? So then some of them are trying medications, blood pressure medication that seem to work in the heart. We think, and then I intensify the sickle cell treatment. Now that I have more treatments to offer, I'm going to start thinking about adding things to hydroxyurea. Such as the new drugs. So the voxelotor, crizanlizumab, and then think about, should I be sending this patient to transplant? Because I think it does revert organ dysfunction in some cases. And gene therapy maybe, right? So then I'm more aggressive pushing treatments on the patients.
Well, I mean, gene therapy is still very expensive.
It's very experimental, right? And we still don't know to the extent to it can work. We don't know yet the rate of success. A few cases have been done and seems very promising. I am very optimistic, but I don't even know how much it costs. I would think it would be, I don't know, in the range of $1 million.
I'm sure,
I don't know.
I was going to say half a million.
$500,000 sounds right. Yeah, more. Yes, I think it will be.
It'll be a while before we...
It will be a while, but I'll be off limits for a while. Yeah, very investigation at this point.
So how often would you refer a patient for transplant, and what would your criteria be?
So what I do, I discuss with everybody, all my patients since they're little. I say, okay, this is what we have to treat. I'm not saying you need to go on any of these treatments right now, but I want you to know. So we begin with the parents, right? I say there's hydroxyurea, there's transfusion, there's transplant, there's gene therapy coming, and they are the new treatments that just came out. I discuss everything, and then I remind them. And I have my nurse practitioners and PAs and nurses discussing options of treatment. So then the parents sometimes say, I don't want to wait for a problem. I want to start right now. Right. So we do hydroxyurea a lot, right? Even without symptoms in the small children. But then if they start having more pain and complications, then I am more aggressive pushing treatments. Yeah.
Okay.
But I want them to know.
Now, what's totally different between Europe and North America is money.
Yes.
Who pays for all this?
Access to care is a huge issue here, right? So
I know it's not PC, but I'm going to ask you anyway.
So I think, it's sad that U.S. has one of the best medicines in the world, but it's off limits to a lot of patients. So access is a huge issue. So who pays for that? If you're lucky enough to qualify for Medicaid or Medicare, you get paid under those plans.
Okay.
If you work, you can get private insurance. We get a lot of denials sometimes for lab tests that we order. Like sometimes I order brain MRIs and I get denials, and I have to appeal. And it's a lot. I have to call again. And then the drugs. I'm a little concerned about the new drugs, the cost. So I've ran some costs with my pharmacy, and the new drugs are going to cost in the vicinity of $100,000 per year. So I'm concerned about access.
Which is off limits to the vast majority of people, I would have thought.
Yeah, if your insurance covers it, fantastic. I'm gonna write a prescription, but
And if it doesn't, you won't get it.
they don't. But they're new, right? So
Yeah.
I haven't really accumulated experience. I know that L-glutamine, which is the drug that was approved 2 years ago, I get denied about half the time, and then we have to appeal. And then, most of the time we're successful getting coverage under Medicaid
Right.
for Indari. That's the commercial name. But the no drugs, Oxbryta and the crizanlizumab, what is it called? I forget. It's crizanlizumab voxelotor, the new drugs. I haven't prescribed yet because they just got approved this month.
Okay.
So I am hopeful that the insurance companies are going to cover it.
So next year, hopefully.
Next year I will know. Yes, yeah.
Listen, thank you very much indeed
Absolutely, Shaun. Thank
for
you so
sharing your
much.
thoughts with us. And
Yes.
for you young investigators and clinicians out there, this is a very complex disease. And obviously, as we've heard, access to new therapies is extremely important. But hopefully, as time goes by, access will become more widely available and physicians will know what they're doing or what they're supposed to do.